Hello, and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shanagan. Gastrointestinal symptoms are some of the most troublesome complications of scleroderma, affecting more than 90% of patients and causing significant distress. But how does the microbiome, and particularly microbiome-derived metabolites, play a role in these symptoms? The manuscript we will discuss today is Characterization of the Fecal Metabolome in Patients with Early Systemic Sclerosis. It was published in ACR Open Rheumatology, and a link to the manuscript and disclosures can be found in our show notes from today. I'm thrilled to be joined today by the senior author of this manuscript, Dr. Elizabeth Volkmann. Dr. Volkmann is director of the UCLA Scleroderma program and co-director of the UCLA Connective Tissue Disease Interstitial Lung Disease program. She is an internationally recognized expert in systemic sclerosis and connective tissue disease-related interstitial lung disease. Dr. Volkmann graduated from Sonoma College, where she majored in neuroscience and minored in dance. She received her medical degree from the David Geffen School of Medicine at UCLA, where she subsequently completed an internal medicine residency and a rheumatology fellowship. While she was in fellowship, Dr. Volkmann participated in the Specialty Training and Advanced Research, or STAR program, and earned her Master's of Science in Clinical Research. Dr. Volkmann led the first study to investigate the gut microbiome in patients with systemic sclerosis, and she now leads an international consortium of investigators dedicated to understanding how the gut microbiome contributes to inflammation and clinical symptoms in scleroderma. Welcome back to the show, Liz. You had joined us about a year ago for an ACR Convergence episode, but it's great to get you back to talk to us now about your research. Welcome.
Thank you, Vicky. I'm so honored to be with you again today, and I'm happy to share my insights with you.
So there were a couple of studies that laid the groundwork for the study we're going to be discussing. Just to bring us up to speed, could you tell us about the gastrointestinal symptoms in the very early diagnosis of scleroderma study? I think it's also known as VDOS.
Yes, I'm absolutely happy to share this with you. Before, historically, we thought that gastrointestinal symptoms occurred later in the course of scleroderma. And this was often because we weren't asking patients the right questions when they had early signs of systemic sclerosis or even were diagnosed with the disease. And patients sometimes are somewhat reluctant to share their gastrointestinal symptoms with their providers. These can be more personal or private experiences. So unless a physician asks a patient about them, they might not get the symptoms that the patient is experiencing related to their GI tract. So there's been some excellent work looking at patients with very early systemic sclerosis. And as you said, we call this the VDOS patients. And in these studies, we're seeing that patients sometimes have gastrointestinal tract symptoms before they even have Raynaud phenomenon, which is what we thought was always the first symptom of scleroderma. Early on, these symptoms can be quite subtle. Patients might experience some acid reflux or heartburn, but they might think, oh, maybe I have heartburn because I'm eating the wrong food. They may also have some bloating or constipation, but it's very common that someone might think, well, this might be because I'm just stressed or I'm dehydrated. So oftentimes these symptoms can be misattributed to other factors going on in a patient's life, when in fact they can be due to early systemic sclerosis.
And there's also been some background into how the microbiome differs between patients with scleroderma and those without. What have those studies shown in the lead into this work that you're describing today?
Yeah, that's an excellent question. When I was a fellow at UCLA and I was starting to do research in scleroderma, one thing that I noticed was that when patients would come to the clinic, and let's say they had a digital ulcer infection or a urinary tract infection and they went on antibiotics, miraculously, a lot of their GI symptoms would improve. And it would be a temporary improvement, but it was enough that the patients really enjoyed going on antibiotics because they got some relief from either their diarrhea or constipation. And this is what prompted me to do the first investigation into the gut microbiome and systemic sclerosis. where I collaborated with a wonderful pathologist who was an expert in inflammatory bowel disease. And we did colonoscopies in patients, and we sampled during the colonoscopy from the cecum and sigmoid colon. So we did what's called a colonic lavage, and that's taking the fluid and bacteria that are adherent to the mucosa in those areas. And then we compared what we saw in the patients with scleroderma to unaffected patients that were of a similar age and a similar proportion of males and females. And what we found was that there was marked dysbiosis in the patients with scleroderma. And what I mean by this is that the patients with scleroderma had a higher abundance of bacteria that we call pathobiont. These are bacterial genera that have been shown in other studies to promote inflammation. And then they had a lower abundance of what we call commensal bacteria, the bacteria that we think help protect against inflammation. And this was really the first study to investigate the gut microbiome in systemic sclerosis. And since this time, there's been a number of investigations throughout the world showing that patients with systemic sclerosis have distinct microbial profiles compared to those who do not have systemic sclerosis.
Wow, it's fascinating. And I love that that came out of an observation you made when you were a fellow. So, what led you from that series of observations to study the microbiome-derived metabolites in scleroderma? Can you tell us a bit more about what these metabolites are? What do we know about why they might be important in the pathogenesis of scleroderma symptoms?
Great question. So, as I mentioned, we and others have shown that there are differences in the gut microbiome. So, the abundance of specific bacterial genera, and now we're even looking at the species level. But what we want to understand now is how do the bacteria interact with the immune system? How do they actually promote inflammation, not only within the gut, but even distally in other organ systems, such as the lungs and other areas that can be affected in systemic sclerosis? And the metabolites might be a key intermediary in this process. So, bacteria produce metabolites, and these metabolites have been shown in other disease states to be altered. So I'll give you an example. In inflammatory bowel disease, some studies have shown alterations in short chain fatty acid levels. These are a type of metabolite. Other disease states like obesity and diabetes also have alterations in short chain fatty acids. So with this investigation, we were interested to understand, were there differences in the levels of metabolites between patients with early systemic sclerosis and unaffected controls?
Yeah, it's really exciting, kind of brave to do this work and not really know what you find. So tell us how you designed this study. Who did you recruit? What were their baseline characteristics? And how did you evaluate them in terms of symptoms?
Great question. So, I worked with a number of wonderful investigators. With any good research, you're working as part of a team. So, the first author on this paper, I want to highlight Dr. Arissa Young. She's a very promising basic scientist in scleroderma. She just got a faculty position at UCLA, and she works in the lab of someone that does metabolomics research. So, it was a perfect project for her to investigate the metabolome in systemic sclerosis with guidance from her lab mentor and also me on the side of scleroderma. And then we collaborated with Dr. Christopher Andresen, who is a rheumatologist in Lund in Sweden. And what's nice about his cohort is that he sees a lot of patients with early systemic sclerosis. So in this cohort, we specifically looked at patients who had a disease duration of less than or equal to 3 years from the time of their diagnosis. Unfortunately, in the United States, sometimes patients with systemic sclerosis do not make it to academic centers such as UCLA until they have more advanced, long-standing disease. So we don't get the opportunity to always study patients early in the course of their disease. But we were fortunate to work with our collaborators in Sweden, and we looked at patients with this early disease. And the reason why we wanted to look early in the course is that we know as the disease evolves, patients are exposed to different medications. They may change their diet. They may do other things that could affect the metabolome. So we wanted to focus on these early patients. in patients who didn't receive immunosuppressive therapies to a large extent and hadn't changed their diet too much to really understand what are changes that could be related to the underlying disease state.
And so tell us a bit more about the baseline characteristics of the patient cohort. Were they all recruited in Sweden?
Yes. So for this particular investigation, we looked just at patients recruited in Sweden. And then we also recruited healthy controls from Sweden. And this was intentional because we know that diet environment also affects the microbiome and the metabolome. So we wanted to make sure that we were matching patients who resided in the same location and not matching them to patients who live in another country. And so the scleroderma patients in this cohort, this was, a predominantly female cohort, which is very characteristic of scleroderma, where we know there are sex differences with a ratio of 4-1 women to men. We also saw that most people were middle aged, which is also characteristic of a scleroderma cohort. But then importantly, in this cohort, only about a third of patients had ever been exposed to any immunosuppressive therapies. So most were completely treatment naive with respect to their scleroderma.
Yeah, it's really exciting to be able to study a group so early. The analysis that you conducted on the stool samples was quite complex. I wonder if you can tell our listeners a little bit about it and then also maybe share some of the complexity of doing this study internationally, because you shipped the stool samples from Sweden to the United States in order to run this analysis. So fill us in. What did it take?
Moving stool samples around the world, and these were shipped actually during the pandemic. So that added a new layer of complexity to the shipments. But typically, these samples are frozen, and we try to only thaw them once to do our analysis, because we know that if you thaw a sample, then refreeze it, and then thaw it again, it can sometimes affect your results. The other consideration is that we try to perform everything in one batch, because there can be batch effects that we can see when we do these sequencing analyses and when we do the metabolomic analyses. So these samples were shipped to us, and we first did the microbiome analysis, and we have already published that paper. And then we rethawed the sample to do the metabolome analysis, and that's when Dr. Young joined our team. So it's important when we're shipping samples around the world, we try to use a reliable carrier so that we can have temperature monitoring and making sure that the samples stay frozen, and we usually ship on dry ice. And Dr. Andresen, they did a perfect job with shipping, so we didn't have any issues there. And what we found when we did our analysis is that, well, I want to first explain that when you do these analyses, you're looking at a lot of different variables. So we're always a bit cautious about reporting p-values without making the appropriate adjustments. So typically we adjust for things like multiple hypothesis testing to reduce the risk of type 1 error. We also, in this analysis, wanted to adjust for some factors that could potentially affect the metabolome. And these are things such as BMI, the age of the patients, whether or not they'd been exposed to immunosuppressives or proton pump inhibitors. So because we had sort of a relatively large cohort, we were able to adjust for confounders that have been shown in prior studies to affect the metabolome. And this, again, helps give us confidence that what we're seeing are changes due to scleroderma and not due to one of these other factors.
Tell us, what did you find in the metabolome, and kind of give us a bit of a deep dive into that?
Yeah, so we found that one of the interesting things was that the short chain fatty acid levels were actually higher in the patients with scleroderma compared to the unaffected controls. And this was a little bit different than what we were expecting, because in a disease such as inflammatory bowel disease, we often can see lower short chain fatty acid levels compared to unaffected controls, although there have been some studies showing higher levels. But in other disease states like obesity, we do see higher short chain fatty acid levels. So this was, again, an unexpected finding, but just shows that these short chain fatty acids might be altered in scleroderma. And we had a couple of hypotheses for why this could be. And one of the leading ones was that, patients with scleroderma can have malabsorption, so difficulty absorbing things in their GI tract. And one of the things that could be not readily absorbable are the metabolites. So it's possible that we're seeing the higher levels of the short chain fatty acids in the stools purely because they're not getting absorbed as well. And to test this hypothesis, what we're doing now is we're collecting blood samples from the patients along with the stool samples. If we could measure the metabolites in the blood, this might give us some meaningful information, not only about how metabolites interact with the immune system, but also we're able to then see these are the metabolites that are reaching the circulation. What effect could they be having on lung disease, for example?
Yeah, that's really exciting. Are you able to see any differences between, or any correlations between these metabolic differences in fecal short chain fatty acids with the different microbiome profiles that you see in your scleroderma patients?
Yeah, so we did quite a complex analysis where we wanted to see whether these short chain fatty acids and other metabolites were associated with some of the bacterial genera that we saw were differentially abundant in the scleroderma patients compared with the controls. And indeed, there were some important correlations there. And I think these results were more hypothesis generating because it was the first time anyone had ever looked at this relationship in scleroderma between the metabolites and between the bacterial genera. And so we're performing another investigation on this in a different cohort to try to validate the findings now. And what we're doing in this new analysis is we've used a different approach for sequencing the gut microbiome. So we've used something called shotgun metagenomics. So in this paper, we highlighted results using 16S sequencing. And I'll just speak for a moment about the difference between the two approaches. The 16S sequencing has been used for decades to characterize the microbiome, but there's some limitations in that it really can only give you insight into genus level changes. We don't have good accuracy with showing species level differences. But with shotgun metagenomics, you can actually see good species level resolution. So in this upcoming investigation, we're actually looking at correlations between specific metabolites and bacterial species. And I think that might help take this research to another level.
Now, that's really exciting. I'm wondering, and this may be a little speculative, you might not be there yet, but from a patient's perspective, how should we interpret these findings? Is there anything people can kind of change in terms of their diet to modify these factors? And then what kinds of limitations should we take into account as we interpret this data?
These are great questions as well. And I think we still have more work to do in order to link diet to the microbiome. Did actually just publish a paper looking at patients in our UCLA cohort we had them report their ultra processed food intake. And we did see that patients who ate more ultra processed foods had a greater degree of dysbiosis in their gut and also reported more GI symptoms. So, this was one of the first studies where we directly linked a certain dietary issue with the gut microbiome. I think from this paper, we have more work to do to show links between the microbiome and what you should do with your diet. But I'm happy to share some of the things that I recommend for my patients with scleroderma, just based on my anecdotal experience caring for a lot of patients. And one of the things that I think is helpful is to reduce the processed food intake because processed foods have additives, preservatives that have been shown both in animal studies and human studies to disrupt the gut microbiome and likely disrupt the metabolome. I think it's also helpful for patients to consume more of these healthy fats like the olive oils, avocado, flaxseed oil, because these have been shown to have a beneficial effect on the short chain fatty acids. So, those are a couple of things where I think we do have solid evidence from gut microbiome research to recommend to patients with scleroderma and probably to other autoimmune disease patients as well.
Yeah, it's really helpful. Thank you for sharing that. So tell us, how are you and your lab team planning to build on these research findings in future studies, both in scleroderma and then any other diseases that you're studying?
Yeah, so I think that what's come to light in doing this research, we've actually compared the gut microbiome of patients who reside in Sweden with scleroderma to those who reside in the US. And there are marked differences that are probably related to changes in environment, the diet, all of the differences of living in Sweden versus the US. So, what we'd like to do now is to keep creating international consortium of patients with scleroderma to help us better control for the effects of environment to truly see scleroderma associations. So, we now have a wonderful group of investigators that include not only our colleagues in Sweden, but we also have collaborators in Italy and Belgium, as well as Chile, Singapore, and even Australia. And we hope to keep collecting more samples from patients around the world, again, to have a better sense of what is a true scleroderma association and not something that's just related to diet or something about the environment in the area where we're sampling from.
Such important work, and all of this data will really help us better understand the biologic drivers of this disease. So, really thrilled that you're doing it. Now, I have a kind of deeper question, taking you in a slightly different direction. In your UCLO bio, you emphasize that you take a very holistic and personalized approach to clinical care. Tell us a little bit more about how you see scientific research supporting these holistic approaches moving forward, and what do you think we could do more of as scientists to make this the norm?
That's a great question. And I want to explain first what I mean by holistic medicine, because I think in the current climate, some people interpret holistic medicine as, completely abandoning Western medicine and modern medicine. But what I mean by holistic medicine is really treating the whole patient. So when I see patients in the clinic, I don't just treat lupus or treat scleroderma, I treat the person. And so it's looking at the biology, what's going on in their body, but it's also looking at their diet, their lifestyle, stress that could be going on. And really, I found early in my career that rarely could you cause complete remission of an autoimmune disease simply by giving an anti inflammatory medication. But I saw that when patients went on a journey to adjust their lifestyle, to get rid of stressors or find ways of coping with stressors, they really began to transform their health. And I think if we're going to do research to understand this, we might even have to think about doing research in a different way. Maybe the placebo controlled trial is not the right way to look at lifestyle interventions because they have to be so personalized. And I think there's been some great examples of the NIH, for example, funding research, looking at complementary and alternative medicine and looking at it in different ways than that normal randomized controlled trial model. I think that this will help move forward this field and get people to understand how much lifestyle affects someone's health.
Yeah, I totally agree. And I think it's a really important thing for scientists to do because we know these factors all interact. And so we won't be able to understand it unless we study it scientifically. So I'm glad you're doing that work. You've managed to really balance providing exceptional holistic care for your patients, looking after people with really complex scleroderma and interstitial lung disease, but you've also been able to develop this groundbreaking career in research I'm wondering what strategies have really helped you succeed in both roles, and is there any advice you would share with early and mid-career researchers who aspire to follow a similar path?
And that's such a nice compliment coming from someone who's so accomplished in their field. I'm very touched. I would say that everything that I do, be it the research, the mentoring I do, really comes from the patients. So all of the research that I pursue comes from questions that I'm trying to answer in the clinic to help people live better lives. So as I mentioned, seeing that antibiotic observations really sparked me to understand how the gut microbiome contributes to disease. I have this new RO1 now looking at molecular imaging, and this came from not really having good ways of measuring treatment response for interstitial lung disease early when we start medication. So I think that, if you're embarking on a career as a researcher and as a clinician, if you're inspired by what you're doing and you really listen to patients, they will tell you the areas that they need help in. And if you keep that as your goal, you're not just furthering your own career, but you're doing something to help people. And a lot of times, I know that these diseases are rare. I'm not going to change the whole world with what I'm doing, but I do find that if I can make one person's life easier on a daily basis, this gives me a lot of satisfaction.
Oh, I think that's really incredible advice. And I love that everything you do is inspired by your patients. I think it's speaking to the importance of that bidirectional relationship that rheumatologists are lucky enough to forge with their patients. So thank you for sharing that point. You have obviously also been really successful in building these multidisciplinary collaborations. And I'm wondering, do you have any tips for other scientists on how to forge a good collaboration? In this study, you talked about your relationship with the scientists in Lund, Sweden. I'm wondering, from that, can you share how you designed this study together? Was there anything you learned through this collaboration that you wish you'd known before you started?
No, it's a great question. And I think that, the American College of Rheumatology has provided a wonderful opportunity every year through the Convergence conference that they host to engage with other people. And a lot of my collaborations have come from the poster session where you might be standing at your poster, walking around looking at other posters. And this is how I've met some of these other investigators. And I would say that having this in-person connection can really help with promoting multidisciplinary research. I also go to other conferences, so in the pulmonary space, and I'm hoping in the future to go to some GI conferences. But I think when you have these direct interactions with people, this is the best way to connect and start a collaboration. And I don't think that we can do research anymore just only working with people at our own institution. It's really important to broaden the scope, particularly for rare diseases. And like I said, we've benefited so much by collaborating with people in Europe because in Europe, they do see these patients with early disease at their specialty centers. Us in the US, we benefit from having these collaborations, and I hope that they benefit too from the technology that we're providing because we're doing all the sequencing for these studies in our lab at UCLA.
It's so exciting that you've been able to build this collaboration. Was there anything that you wish you'd known before you started in terms of the complexity of the collaboration?
That's a good question. I would say that you learn as you go along. So I don't think you can ever be prepared and have all of the answers at the beginning. So for example, when we started this, we had no idea that a global pandemic was going to happen, which affected a lot of countries' ability to ship us samples. And I think that just learning as you go, the obstacles that can arise, you're not going to be able to anticipate every obstacle. I mean, I think that our material transfer agreement between Singapore and UCLA took almost 3 years to execute, which is a pretty long time just for sending stool samples. But we didn't give up. And I was so grateful that the investigator on the Singapore side just kept moving through and working with her team there so that we could reach an agreement that satisfied both parties. And I think that just knowing that you're going to have challenges that come your way and you'll have to tackle them, but just don't give up with these obstacles, because at the end of the day, I think this multidisciplinary research really will help elevate the field.
Yeah, I think it's really important for people to hear that, because oftentimes people see you present, see you publish papers, and they don't realize the real granular nitty-gritty that it took to get something over all these hurdles. So thank you for sharing.
Yeah. And the other thing that I think is valuable and something that I try to always promote, Vicky, I do a lot of mentoring of young investigators, and this is something I'm quite passionate about. But when we do engage with other collaborators in other countries, I make it very clear that we're happy to support the junior investigators there that might be the ones doing a lot of the groundwork, running around, collecting stool samples in the clinic or entering data into the REDCap database. So we offer the junior people who participate co-authorship on the papers. And I think that this, again, helps the field grow, because we're not just looking out for the senior people in the field, but we're helping, others rise up in their careers as well.
Oh, I love that. Thank you for sharing that. So looking ahead, Liz, what do you think will be the future breakthroughs or innovations in scleroderma that are coming down the pike? What excites you most? And how do you think that clinical care for this disease is going to change over the coming years?
Well, I think with the wonderful work that's being done on these patients with very early disease, there's now interest from the pharmaceutical industry and even targeting patients early in the course of scleroderma with preventative therapies. So instead of waiting till someone has significant damage in their lungs or in their skin or other organ systems, there will hopefully in the future be intervening early when there's just some signs of inflammation or early signs of fibrosis or scarring, with therapies that might help reverse damage and prevent damage from accruing in the long run. I'm also really excited about the possibility of cellular therapies and the role that they may play, again, in reversing these diseases and leading to sustained remissions. There's so much excitement now in these rare diseases that I think that the future is going to be very bright. And at the same time, I do a lot to try to educate and empower my patients on the changes that they can make in their own life to feel better. Because I do think that when people are diagnosed with autoimmune diseases, it can feel very much like their body is out of control, that they are a victim to a terrible disease. And feeling this way can actually make the disease worse. And when people learn to take back control of their health and do these small things on a daily basis to improve how they feel, sometimes they become less of a victim of the disease and more of just an active participant in their healthcare.
Yeah, I think it's a really important message, and I appreciate you sharing that. Liz, I want to really thank you for such an engaging conversation today. I always enjoy our discussions and always come away with unexpected insights and wisdom every time we talk. So thank you.
Thank you so much, Vicky. I appreciate you taking time to do this. I know what a busy woman you are, and I'm so grateful to speak with you anytime.
So as we wrap up today's episode, I also want to thank our community of international scientists, collaborators, and patients around the world. These complicated studies demand patience, creativity, and relentless determination. But every sample collected and every dataset analyzed brings us closer to better treatments and improved outcomes for autoimmune diseases. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media, email us at podcast@rheumatology.org, and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.
This podcast was edited by Resonate Recordings.